I would like to speak after my distinguished colleagues who spoke about the MRI diagnosis. First of all, I have no conflicts of interest related to this presentation. Clinically, we all know that there are no specific diagnostic tests available yet, and history is still the most valid test. MRI diagnosis may be a very important aspect for patients in the future, patients who are mute or cannot express themselves for some reason, but I think it's very important to examine patient during the acute episode. When we have the ability to examine the patient, we can see that there is spontaneous nystagmus beating towards the healthy ear, which obeys the Alexander law, enhanced by visual fixation. There is generally positional nystagmus, but this is always in the direction of the spontaneous nystagmus, in contrast to the vestibular migraine. It's very important, I think. In every position, nystagmus does not change and always beats in the original position. Recently, we had a position statement paper, and these papers are helpful for those people who are dealing with the diagnosis of treatment of Meniere disease. Also, I think that before considering any treatment, disease-specific quality of life surveys are essential to analyze the relationship between the findings or the vestibular findings and the disability scale of the patients, complaints of the patients. And also, as once stated before, any proposed treatment should take into account the high rate of remission during the natural course of the disease. For that reason, non-destructive treatments should be chosen in the first place. And this is the famous treatment ladder, and the steps are changing every time. But at the first place, we explain the disease and support the patient, and then use medical treatments. And in the second steps, we switch to intratympanic treatments. Now, I would like to speak about intratympanic treatments. Although sophisticated drug delivery systems for inner ear treatments are the hot topics of research nowadays, the current standard is transtympanic treatment. What I do is to create a two-hole technique in the anterior superior quadrant and just pour the drug through one hole and let the air escape through the other, and try to fill the middle ear while the patient is turning his or her head 45 degrees in the opposite side and laying down for 10 minutes. With dexamethasone, I prefer to give 4 milligrams in milliliter, and I do it 3 times, 1 time for a week for 1 or 3 weeks. And if I have a significant effect of treatment, then I put grommets and continue with topical dexamethasone. But I mostly prefer intratympanic gentamicin, and this is a low-dose treatment, single-shot treatment, and I assess the patient at 1 week later and repeat, if necessary, up to 3 consecutive weekly injections. And I closely monitor the patient with defined cutoff points, the video heat and color tests, I mean. And with that treatment regimen, I can say that I have encountered no sensory hearing loss, no significant sensory hearing loss. And sometimes I had patients with occasional improvement of hearing due to resolution of the hydros. Recent papers show that intratympanic methylprednisolone and gentamicin were similarly very effective in Meniere disease. However, I think that, as I said before, I'm convinced so far that low-dose intratympanic gentamicin is more effective with a very low risk of sensory hearing loss, and I prefer to use gentamicin after medical treatment in case of intratympanic treatment needs of the patients. In an animal study with my colleagues from Italy, we showed that a combination of intratympanic gentamicin and dexamethasone was not harmful to hearing and had the same vestibular toxic effects on the vestibule. And also, in another study, we described the protective effect of dexamethasone-loaded hydrogel on a model of cisplatin ototoxicity. And also, our center is also involved in the phase 3 clinical study of the first commercial intratympanic injection to come. And lastly, I would like to say a few words about the role of surgery in Meniere disease. We should realize that there are only two treatment methods which are mainly targeted to the underlying physiology of the disease. The first one is intratympanic genta injection, which reduces the production of endolymph. And the second one is sac surgery, by some means that we still don't know, enhances the functions, the drainage and absorption functions of the sac. The other treatments, surgical, can be considered as symptomatic treatments. Endolymphatic surgery, by some means, helps these patients. I would like to show a 1-minute video. It's a regular practice to find the sac, and currently we are using endoscopes to better visualize the sac and the duct. And also, we are trying to see inside the sac in a hope that we can find something to help us with the treatment. It's a good practice to instill dexamethasone inside the sac or around the sac in order to have a better control of vertigo. But the papers are conflicting about the effect of dexamethasone injection combined with endolymphatic sac surgery. Some say that it's helpful, some say that it's not. Generally speaking, the control rate of vertigo at 2 years is around 60%, independent of the technique used during sac surgery, I mean enhancement, decompression, ablation, or whatever technique. And there may be some hearing improvement in those patients. So I think that there's a current role in selected patients after intratympanic treatments who do not respond to intratympanic gentamicin, I think. And this is the famous, somewhat notorious Denisham study. But we know that the reanalysis of this original data supported the effectiveness of endolymphatic sac surgery, which was almost abandoned for a couple of decades. So this is the end of my talk, and I'm ready to answer your questions or your comments. Thank you for your attendance.